Good evening, everybody, and welcome to our webinar this evening. We're going to be presenting to you on the topic of arteriovenous malformations and the role of stereotactic radiosurgery in the form of gamma knife. I'm joined by two of my colleagues from the National Hospital, Interventional Radiologist Dr. Prem Ranngi and Neurosurgeon Mr. Patrick Grover. And we are also delighted to welcome Senior Neurosurgeon from Sheffield with enormous expertise in this field, Mr. Matthias Radatz. So the format for the evening will be that each of the colleagues will make a brief presentation, and during that time, you are welcome to post questions for us. In fact, please do post questions, because there's lots of time at the end of the presentations for us to go through the questions and answer them and discuss your cases or your questions in lots of detail. So if you look on the right side of your screen where the chat box is located, you can insert questions there at any time during the webinar. And as I said, please do, we'd be delighted to answer your questions. So we'll get started shortly so that we have plenty of time for questions at the end. But at the very end of the presentation, I'll give you a little bit more information about how to make referrals if you have patients with AVMs that you'd like us to see, and also how to join our multidisciplinary meeting, which is a virtual meeting which occurs twice a month, and which you'll be very welcome to join. So without further ado, let's get cracking, and I'll ask Dr. Prem Ranngi to speak to us about cases which are and are not suitable for gamma knife. So features that we're looking out for when we are considering an AVM for various different types of treatment.
Good evening, ladies and gentlemen, and welcome to the webinar on AVMs at the Queen Square Gamma Knife Centre. As Mary has introduced, I'm Prem Ranngi. I'm an established consultant interventional neuroradiologist. I've been practicing for 15 years in the NHS as a consultant. Before I start on my slides, I'd like to just contextualise the subject matter for today's discussion and give a broad overview perspective of what the UK endovascular treatment of cranial AVMs is, broadly speaking. Now, in the UK, there's approximately in excess of 140 interventionists who are established in treating AVMs. There are readily accessible treatments for patients presenting acutely with AVMs. Typically, this involves the treatment of flow or intranidal aneurysm treatments. However, this contrasts quite differently to elective embolizations of patients with AVMs. And to the best of my knowledge, there are 4 or 5 practitioners in the UK, including myself, who regularly take treatments for elective treatment of cranial AVMs. So, with the exception of those patients who would receive surgery, the vast majority of patients who have a cranial AVM will be treated by gamma knife therapy. And the rationale and reasoning behind this will be explained a little bit more as my slides go through. So the treatment principles for an AVM are relatively simple and straightforward. We want to achieve occlusion of an AVM and clearly avoid any of the adverse consequences. As I'm sure most of us are very well aware, there are 3 treatment modalities available for the treatment of cranial AVMs: embolization, surgery, and gamma knife. These can be delivered either in isolation or in combination. And typical examples of combination therapy would be embolization followed by gamma knife, or embolization followed by surgery. Just occasionally, gamma knife treatments need adjunctive therapy either with embolization or surgery, and I'll share an example of that. All 3 treatment modalities work by vessel occlusion. Now, for endovascular and surgery, that vessel occlusion of the nidus is relatively quick, usually over several hours from treatment commencement. This contrasts with the gamma knife, which works on the vessel wall, but also over a very protracted period of time, typically years, if not very, very many months, before achieving occlusion of the AVM. Now, this slow process of vessel occlusion by gamma knife is what probably infers it's significant reduced morbidity compared to embolization and surgery. At Queen's Square, we have a very robust and established governance program for managing cranial AVMs. The vast majority of patients will enter the Gamma Knife service via referral to the Gamma Knife MDT. The patients can also enter the Gamma Knife service via referral to the neurovascular service, and occasionally patients are reviewed both in the Gamma Knife and the neurovascular MDTs for a more comprehensive review if they've got more challenging cases. Patients can also be reviewed in the complex neurovascular clinic, and importantly, this is chaired by a neurologist who will not only conduct the primary discussion with the patient, but indirectly acts as the patient's advocate, ensuring that information is provided in an unbiased and fair manner. Patients typically are seen 2 or 3 times over several months before a final decision as to which treatment modality to proceed. Now, in order to answer the question, what makes AVM suitable for radiosurgery, we need to look a little bit more closely at what's happening at the nidal interface at the time of embolization. And at the top of your slide, you'll see 2 examples of AVMs treated successfully with embolization, both patients treated without clinical sequelae. So I suspect some of you are asking, why don't we treat more AVMs by embolization? Well, the answer is simple. What's not apparent on the angiogram is that intermingled with the nidus is neuronal tissue. The functionality of that neuronal tissue will be variable from one AVM to the next. For large AVMs and those that have a diffuse nidus, there is quite significant neuronal function. And you can see that a quick or rapid reduction in arterial supply to the nidus has consequences to that neuronal tissue and can result in local ischemia and therefore, particularly where there's eloquent parts of the brain, and neuronal sequelae. Broadly speaking, there are 3 considerations when we undertake treatment considerations for AVMs: location, size, and angio-architecture. The most significant single factor when deciding for treatment for an AVM is location. There's a very strong direct correlation between eloquent parts of the brain and treatment-related adverse sequelae. Those sequelae are least or reduced by Gamma Knife therapy, partly at least because of the mechanism of way it behaves on those nidal arteries in a more slow and more gentle way compared to embolization or surgery, which is a more abrupt cessation of flow in the nidus. Now, large AVMs are problematic both for surgeons and interventionists. Undertaking a large embolization of an AVM in a single setting is problematic and associated with a high incidence of post-procedural hemorrhage and risk to life. However, the example shown in the bottom of your slide shows a large AVM with supply both from the anterior and posterior circulation, which was effectively managed by Gamma Knife. You can see on the follow-up at 4 years, there's a relatively small remnant which can be successfully treated by adjunctive embolization. So to summarize, the management of AVMs is complex. There is not only hope, but a realistic prospect of a curative result with Gamma Knife in selected patients. Thank you very much. I'm going to now hand over to my esteemed colleague in Sheffield.
Thank you very much for the introduction, and thank you very much for asking me to give the overview talk on radiosurgery in Sheffield on this webinar. How did stereotactic radiosurgery come into play, and how did it come to Sheffield? So the fundamental baseline for this is the work of Ladila Steiner in Stockholm, who showed that irradiation of an arteriovenous malformation nidus leads to a complete obliteration of this nidus, and that it was vital to irradiate the whole nidus and not only part of it or the feeding arteries. The effect of the radiation treatment is complete obliteration of the abnormal vasculature within the AVM nidus. This is achieved due to the irradiation effect, the intima irritation, leading to myofibroblast immigration and collagen deposits, leading to a complete obliteration. So it's typically permanent once that is achieved. Now, how did it come to Sheffield? David Foster was working in Stockholm with Lars Lexell on the prototype gamma knife there, and they started irradiating arteriovenous malformations. He presented their first results to the Society of British Neurosurgeons in Plymouth in 1979, and showed in his talk that 84% of these lesions were obliterated within 2 years after the irradiation treatment, and only 5% did not show any effect. This led to a very large interest of the society, the president and the secretary, trying to establish a gamma knife unit in the UK. And because David Foster was working in Sheffield, this is where the machine went in 1985. That was funded as a research project in the first instance. What is important for stereotactic radiosurgery is you have to have a definable sharp target. It needs to be visible on MRI, CT, angiography, preferably on all modalities. Ideally, for the high dose radiation we deliver, it needs to be small and it needs to be sensitive, which we know from Ladilor Steiner's work that AVMs were sensitive to such radiation treatment. The stereotactic steps are the imaging definition, then the dose planning of the target, and then the sharp submillimeter accurate dose delivery to a high rate, which is important. And the dose delivery can be achieved with a gamma knife extremely precisely. This is our Sheffield experience, over 7,000 AVMs, typically between 200 and 300 a year. That is about 44% of the natural incidence of AVMs in the UK annually. You can see a tail off here about the figures about halving, because that's the time when National Health Service commissioning included Queen Square to treat arteriovenous malformations as well. So there are 2 centers super specialized in this work in the UK, treating about that number of patients. So it's a very significant group of patients. And it is the attitude to stereotactic radiosurgery has very much changed over the decades, from the original pioneering work, early good results, to an establishment of a primary treatment procedure fully established in an MDT process nowadays here in the UK. So stereotactic radiosurgery is a mainstay in arteriovenous malformation treatment. It remains a multidisciplinary modality. It is important to have everybody on board, the endovascular specialists, the radiation specialists, and the surgical experts. And many of those treatments will require an overlapping of treatments, like Prem already showed. Good results of smaller, reducing the volume of a very large, formidable AVM, making it amenable for embolization in the second round. The main importance is that the choice is the one which is the least risky with the best result in the long run for the patient. So what are the deciding factors? Urgency is a deciding factor, expected success rate, and the expected risk. And that all is down to the MDT to establish what is the easiest, the least risky, and most successful route in the first instance, and that is put forward to the patient. What we know from our years of experience is that we are very successful in Spätzler-Martin grade 1s and 2s with over 80% occlusion rate after 2 to 4 years. Spätzler-Martin grade 3, 75%, and then in the 4 and 5 Spätzler-Martin groups that tails off to about 50–60%. And I come to more detail a little bit later in this talk. The same applies for the maximum diameter, and that is closely linked to the Spätzler-Martin grading. Smaller volumes and smaller maximum diameter, high success rate. The larger the lesion, the lesser the success rate. We looked at over 5,000 consecutive cases, and what we noted is that over 1,400 of those were considered as large arteriovenous malformations with over 3 centimeter diameter. We analyzed that group, and you can see from the Spetzler-Martin grading what formidable group that is, with 47% of grade 4s and 2% grade 5s. And the majority of those had neurological impairment, so significant pretreatment morbidity due to hemorrhage or due to vascular steal. The patients who had increasing seizure activity usually didn't have such a bad pretreatment morbidity status. So it is an important group, and that is why we treated those. What we established at the same time was a hemorrhage risk analyzing these groups, and found that patients who have never had a bleed before, the lesion was hemispheric, less than 1% hemorrhage risk annually, whilst the deep eloquent placed lesions had a significant higher risk of 7%. Once you bled, then that risk materially increases, 6.6% in the hemispheric and group, and in the deep eloquent group over 16%. So very material risks. What we could show in that large group is that with increasing quality of the imaging modalities over the decades, with MRI and angiography to optimize treatment, nidus definition, etc., we managed to get to about 50% occlusion rate. And we managed that with a reasonably small risk of 9 to 14%, 9 in the more specific and sophisticated later groups with MRI and angiography planning, and a very sophisticated dose plan. Nevertheless, we always wondered why we didn't have more than a 50% occlusion rate, because that seemed quite low. And so we looked at the group in a bit more detail and found out that lesions which were pre-embolized had actually a materially lesser chance of being obliterated with the same treatment, with the same dose, with the same isodose planning, and that patients who had not been embolized had a better chance by 10%, up to 60% cure rate. So that was even more apparent when we looked at the overall volume. So the bigger the volume of the AVM, if they were embolized, the risk of not having a curative effect from the radiation treatment was materially larger, i.e. the success rate was better with no embolization in place. So what is the reason for this? We get often patients who come and have patchy embolizations where we end up treating the full nidus. Very rarely we get good embolizations where a significant nidus reduction is achieved. Often, even if the angiogram looks promising, there is an intranidal contrast enhancement on contrast MRI indicative of a persistent nidal activity inside, leading to the need for full radiation of this. I've discussed this hemorrhage risk rate already. The reduction of complications really is our main interest. And because we still had 9 to 15% of complication rates in the large group of AVMs, we started to fractionate these and in a staged fashion. So what we would do is having a large AVM portioned up in 2 or 3 portions prospectively, and then treat them in a series of treatments 3 to 6 weeks apart from each other. You can see that the group is as formidable as a previous one, which was a single dose treatment. And what we managed to achieve is a reduction of the adverse radiation effects to 6.5%. And if you remember, that was 15 to 9% in the single dose group. Now, the question was, does it come as a price of loss of obliteration rate? And that it is not the case. So we could show that with in the non-embolized group, single stage versus the stage treatment, the obliteration rate was the same. So hence, we treat these large lesions now all in a volume staged fashion. In summary, for the large AVMs, single fraction radiosurgery, 50% obliteration, outcome better if not embolized before 6.5% ARE, and we prefer to treat them de novo without pre-embolization. Very rare there is disabling morbidity caused by the radiation or post-treatment hemorrhage, and the mortality is very low. Now, I'm coming just to conclude on the pediatric arteriovenous malformations. In light of the Aruba, our pediatric group is again a large group. The group is very different because children often present with hemorrhage in over 80%, which is very different to the other adult AVMs. 8% with epilepsy. 82% in our group managed to be obliterated. Only 3.6 complication rate, and the post-radiosurgery rebleed rate just 2.2%. So in summary, with the Aruba in mind, children present typically with hemorrhage. Life expectancy and recurrent hemorrhage risk makes attractive treatment very attractive because there's a high lifetime risk, and parents usually decide to go with active management. And now to conclude, the most important bit really for the MDT and for every individual involved in the treatment is to know their limits, to know what's operable, to know what's treatable, and only set out to treat if the end goal is reasonably expected to be a cure. If one doesn't anticipate to cure the patient, one should not start treating. Thank you very much to the team in Sheffield, and now I hand over to Patrick Grover.
Hello, everybody. Thank you, Matt, for an excellent presentation. I noticed there's a few questions in the chat, particularly relating to stage treatment, and I'm going to go through a presentation of a complex case, which includes staging, and hopefully will answer some of these questions. So we have a 19-year-old gentleman, and he presented with 2 partial motor seizures with secondary generalization. He has a background history of chronic headaches as a teenager, and he's treated medically with levetiracetam, and the seizures are controlled. There's no evidence of any bleeding clinically, and he has an MRI scan which doesn't show any bleeding radiologically, but there is this configuration of what appears to be an arteriovenous malformation in the left hemisphere. He also has no neurology on examination, but you can see that this malformation is sited within the precentral gyrus, so in a very eloquent area in his motor region. There's tangular vessels, which is the nidus, and then you can see the large draining vein, and the next course of management is an angiogram. He has this angiogram. We can see in the left panel is the left vertebral injection. And then there's an AP and a lateral internal carotid injection. It's a very high flow AVM. It's fed predominantly by these enlarged middle cerebral branches. The nidus here is approximately 4 to 4.5 centimeters in maximum diameter. And then there's this very dilated draining superior anastomotic vein which goes to the superior sagittal sinus. So this is a Spetzler-Martin 3 AVM, and Matt went through the sort of results and outcomes we can expect for this group. Lawton supplement is 2, so the patient gains 1 point for age and 1 point for unruptured presentation. There's also a flow aneurysm, so a flow aneurysm on the in the anterior circulation, and again that pushes us more towards considering treatment versus conservative management due to the risk of that enlarging and rupturing. So, as Dr. Ranngi described, we will review such a patient in an MDT clinic. We'll have a neurologist, a neurosurgeon / radiosurgeon, and also interventional radiologist present. All these cases are discussed in a neurovascular MDT and a gamma knife MDT meeting. We discuss all the 3 treatment options, so embolization, radiosurgery, and open surgical excision. And we set the risks of those interventions against the lifetime risk of bleeding. That risk is variably estimated between 1 to 4% per year. I think more current estimates would be in the region of 1 to 2% per year for purely unruptured AVM. And in terms of the decision making, I think each case has to be taken on its merits, but I find this paper very useful. These are the European consensus guidelines on the management of unruptured brain AVMs, and they give some basic recommendations and schema for treatments, discussions with the patient. For example, for an eloquent AVM, particularly a larger eloquent AVM, radiosurgery is considered to be the primary treatment option, and I think that would be with or without embolization, depending on the case. So we discussed with the patient, we discussed in the MDT meetings, and due to the size, the eloquent location, the patient's young age, and also the flow aneurysm, it was felt that treatment is recommended, and that treatment should be gamma knife radiosurgery. Now, due to the size of the AVM, we then need to consider how we would treat and if this should be staged or if we can treat in one sitting. So when do we consider staged treatment? Well, as Dr. Radatz described, Mr. Radatz, there's a subset of large AVMs which are high risk for alternative treatments, and when they get to over 10 cc's, 10 centimeters cubed, then really we should start to consider staging. And the reason is that we want to reduce the volume of normal brain tissue, which gets a significant dose of radiation. There's some questions in the chat about how we would stage. Ordinarily, it's 2 stages, at least 2 to 6 months apart, but there is significant variation between centers, so you can fractionate in more than 2 stages, and also you can treat beyond 6 months apart, but the most common would be this sort of structure. The planning, so ideally you would plan the stages according to the arterial territories, so the feeding pedicles to the AVM. You would want to treat the draining vein, the foot of the draining vein last, particularly because you don't want the draining vein to close early, because that is the main outflow for the blood into the AVM and would be a higher risk of post-treatment bleeding. In general terms, you aim to treat from medial to lateral and from deep to superficial. And this is the treatment plan for this patient. So first stage, we had 20 gray, 50% isodose. The target volume was 8 cc's. And you can see that the main body of the nidus is treated with those 2 feeding pedicles to the middle cerebral artery, and the nidus, which is in the region of the foot of the large draining vein, is left for the second stage. I'm not sure if you can not see the slide as I can't see the slide. Let me try again. Okay, and stage 2. So this is at 3 months, and this is 20 gray again at the 50% isodose, a smaller target volume, so around 3 cc's. And this second stage, now you can see, is very much focused on the region of the nidus, which is just entering into the very large draining vein. So this is the portion of the AVM which we want to close secondarily to reduce the risk of post-treatment bleeding. And these are the results for this gentleman. So at the time of treatment, you can see the nidus and then the draining vein just anterior and medial. And then at 6 months, there's already significant regression of these abnormal vessels. At 12 months, there's almost complete closure of the nidus on this cross-sectional imaging. And critically, you can see that draining vein is now not visible. So it would appear that the AVM is already significantly reduced in size in 12 months. You could also see this hypodensity around the treatment area, and that's edema, radiation edema. In this patient, that did correlate with him having a small focal seizure. He was admitted to hospital and had a course of dexamethasone over a few weeks with resolution of his symptoms over that time period. And then at 5 years, his cross-sectional imaging demonstrates no abnormal vessels. And at that stage, we go on to perform another angiogram. This is the angiogram, and compared to the previous one that I showed, there's a very significant regression of the AVM. You can't quite see on these images the abnormality, but maybe just here you might appreciate that there is very slow filling of this residual draining vein. So there's some very slowly shunting residual vessels you can't quite see in the arterial phase. From a clinical point of view, he had no further seizures, and a positive aspect also, his headaches improved significantly. He had a plan, he was driving now, and the plan was to wean his anti-epileptic medications as well. So this is an example of a complication that can happen after these treatments. This is transient radiation edema. He had this edema in this area, which did not give him a neurological deficit, but he did have that seizure, and that resolved to no residual deficit, which is the usual course. A small percentage of patients can get permanent radiation effects, and I'll just look at the literature here. So this is a review of patients, of series with patients treated with volume staging, and you can see quite a wide variation in the literature, both in the practice and in the outcomes. I'll summarize this, and essentially most of the AVMs treated are Spetzler-Martin 3s to 5. The volume of the AVM is between 10 and 30 cc's. The number of stages is between 2 to 4, and the interval between stages can vary, as I was describing earlier, anywhere between 1 and 9 months, depending on the center. In terms of the outcomes, broadly speaking, the complete obliteration is between 30 and 50%. That doesn't necessarily describe near obliteration or significant reduction in size, but between 30 and 50% in these major series. A proportion of the patients will have a hemorrhage. And in terms of adverse radiation effects, most studies are reporting between 10 and 15% risk. And the majority of these are temporary, as we saw in this case, a small number of patients with permanent radiation effects. So 1, for example, in this case, series 1 in the next one. This is a meta-analysis we carried out at Queen Square, and this is comparing the overall results for single stage treatments as a comparison. So we can see here transient radiation edema is reported in about 5% of studies, permanent radiation side effects in 2%, and then angiogram confirmed obliteration in about 60% of cases. That's all comers for single stage treatment. There was some discussion had previously about pre-embolization and whether or not that does affect the results. This is our assessment so far, so much smaller numbers, but we have not yet found a significant difference between those AVMs which are pre-embolized and those that aren't. I think as Matt was describing, one of the issues is whether or not the pre-embolization is really planned, or if it's been performed and then gamma knife is a rescue option. I think if you do appropriate territorial pre-embolization and then subsequent gamma knife on the residual, then you can achieve good results. Or, for example, if you take out a very high flow portion of the AVM, but I think with more numbers, we might see if there's a difference here or not. So, in summary, stage treatment is potentially a very successful treatment in appropriately selected patients. The treatment aims to reduce the lifetime risk of bleeding by obliterating the AVM, but there is also the secondary benefit to remember that you can treat the patient's symptoms, such as headaches, for example, in this case, or seizures. The obliteration rates are quite variable, and there is a risk of radiation edema with treatment of any such large AVMs. And in the majority of cases, this edema is transient and resolves with a course of steroids. So I'll hand back to Mary Murphy to chair the questions.
Thank you, Patrick, and thanks to all the speakers for keeping to time and for very stimulating discussions. Matthias will join me for the questions section. And before we go on to the questions, I'd just like to highlight a point that was touched upon in both Matthias's talk and Patrick's presentation also, which is that young patients seem to respond better with gamma knife treatment of AVMs. Their AVMs seem to be more likely to close off, even bigger ones, and they seem to do that quicker as well than adult patients. So that's a cohort where really it is an excellent treatment. And even though one's natural tendency might be to withhold radiation from that cohort because they have such a long lifespan when they might experience side effects, actually the literature tells us that it's extremely effective in that cohort. So we have lots of questions coming through, which is great. And what we will do is Matthias and I will choose questions that you have submitted, and we will answer them in turn. And we may invite Prem and Patrick back for their opinion on various questions. So I'm going to start with a really easy one, which is, what circumstances would you take a watch and wait policy? So it's a good question, and conservative management is something that we consider with every single AVM. And I think the situation where I most consistently will say that we should not do anything is a patient who presents incidentally with an AVM when they're elderly. So for example, somebody who's in their 70s or 80s who's experienced a head injury or had a scan for a completely separate reason, and we've discovered an AVM which has never been symptomatic. So, already they've beaten the odds. The average AVM will bleed once in 50 years. If they're in their 70s or 80s and haven't had a bleed, they haven't had a symptom, then, why would you want to even consider treatment? That said, with every single case that I see them in a multidisciplinary setting, usually with Prem Ranngi, and we would discuss conservative management, and then all three of the interventions. So embolization, surgery, gamma knife, and then where appropriate, a combination of those. But there's almost never a situation where we don't at least mention conservative management. If the AVM looks very aggressive and if it's recently hemorrhaged, then we'd be very unlikely to recommend that, but we always have a discussion about it. So Matthias, would you like to put the question to go next?
Yes, thank you, Mary. There is a question: how often can treatment be repeated, and in what circumstance is this advisable? So, in general term, when is it advisable to retreat? Is that you should have had a reasonable response to the first treatment. If there has been no response whatsoever, then one would question if it is sensible to retreat. Retreatment can be successful even if response has been minimal. That often depends on location as well. And with retreatment, one always needs to consider the additional risk retreatment has, because the more radiation dose you give to the same area, the more likely you are to get untoward side effects. So in general terms, there's no maximum number. We have some patients who had 2, 3, even 4 treatments, with the latter being eventually successful. I think the confidence has grown over the decades, and we are less reluctant to retreat than we were in the early days. But in general, it needs to be sensible. And one would like to see that the first treatment or the second treatment, that every treatment you give has had a success in a way that the lesion is going and responding the way you want it to respond. So one wouldn't give it for good measure. The main important thing is that in the first instance, we would only set out treating lesions in the first instance if we feel that this lesion is overall curable. So if you have from the onset the expectation that you can't cure this, and we do get those referrals, then there is little point in setting out in the first instance. Mary, back to you.
Thanks, Matthias. So the next one we have here is, what is a reasonable follow-up period, and how long post-gamma knife treatment would you expect to pass before follow-up imaging shows biological change? So in terms of the follow-up period, the juncture at which we generally perform an angiogram, which is the acid test as to whether or not there's any AVM remaining, is at 4 years after treatment. That said, we would routinely do an annual MRI and MRA to monitor both the effect of the treatment on the AVM and to keep under review whether or not any side effects are occurring. And obviously, if between scans a patient presents with symptoms, we would always do an MRI scan at that point as well. How long would we expect to pass before we see a response on the imaging? Well, you saw from the case that Patrick showed that there was a significant improvement in the radiological findings at 6 months. And as I mentioned, children respond quicker and better. But in the ordinary course of events, you'd expect at least to be seeing some bit of improvement by the end of the first year. And you can see it's quite a bit before then. But if you're not seeing anything at all by the way of improvement at the end of the first year, it's not very encouraging. Back to you, Matthias.
Okay. Do you need a digital subtraction angiography in all cases? That's a very good question. Which I do like. It's important to answer that. In our view, you need a digital subtraction angiography before you set out to recommend what treatment pathway is the best for a patient. To have a good MDT discussion, you need to understand the anatomy of that AVM in detail. So as a digital subtraction angiography is vital for that. Question is, do you need it on the day of the stereotactic radiosurgical treatment? I think that's a decision of the treating team. Some AVMs, when they are really compact, can be very well documented on MRI and CTA alone. It might be sensible not to repeat a very invasive test, which is associated with some risks in itself. So that I would leave to the treating team. But in general, one digital subtraction angiography before you set out is vital. And then going back to after treatment, this digital subtraction angiography is the golden standard proof of cure. So the case Patrick showed was very good to show how good digital subtraction angiography is to show even tiny early draining veins. And I think that's very, very important to know if you can give that patient a clear bill of health. Back to you, Mary.
Thanks, Matthias. I'd like to ask Prem to come back to the stage. We have a question about imaging that he would be best placed to answer. And the question is, what is the best, or what are the best sequences of imaging in the case of AVM before target delineation? Prem, would you like to discuss the optimal imaging sequences for us, please?
So from a structural perspective, T1 with contrast ideally and T2 weighted sequences seem to be the most reliable. And again, I'm really reiterating what Matthias has said already, is the digital angiogram is actually the gold standard for actually evaluating the angiogram proper. Without that, I think you're kind of on a slippery slope, I think.
Back to you, Matthias.
Yeah, whilst we have Prem on, I think that is probably a question best to be put to you directly. What is the occlusion rate you achieve with embolization, de novo embolization on AVMs you feel are suitable? And when you do take them on, do you discuss with a patient what happens in case that you don't manage to obliterate? Is there a plan electively to go straight to theater to do a curative resection, or how do you approach that?
Yeah, no, that's a really good question, actually, Matthias. I think if you're going to treat an AVM, and I completely wholeheartedly agree with what you've said previously, is it has to be with curative intent. Having a partial treatment actually is potentially more dangerous, whichever modality you've chosen. And you have to be realistic, and I agree with that totally. If you're going to embolize, you have to be realistic. Can you achieve that? Or do you need adjunctive surgery, gamma knife? Preferably surgery in the acute setting and the elective setting, if that's the scenario. All the patients that go for embolization are consented with the premise that if there is a need, they will go to surgery as well. No procedure for endovascular treatment goes without surgical presence in the department. I think that's critical, and patients need to be fully aware of the likelihood of that happening as well.
There's another question: is if staging is becoming more commonplace when assessing suitability at an MDT. I think staging is becoming more suitable and more commonplace because we know that we can reduce radiation-induced side effects with that. So as soon as you have a lesion of a certain volume in a very eloquent part of the brain, it would be foolish to treat to a large volume when you go and can volume stage that lesion, knowing that you will have a lesser radiation side effects from it. And we know that it is not affecting the cure rate of an AVM. So overall, in general, it makes a lot of sense to stage when the volume exceeds 10 to 12 cubic centimeters. That's what we would usually advocate nowadays. So apart from Aruba, is there a robust RCT to guide the treatment choice what to do? No, there's no robust RCT. I think it is very important to realize that you require to have a good multidisciplinary team. And that needs to function along a good governance structure. It needs to be carried out in a hospital and in a unit with sensible review of their own results, and to establish, if something is amiss, and to follow a good practice. In general terms, I think all three modalities are suitable, and it is in the patient's interest that we all focus on what is best for the patient. And that is sometimes difficult because, we are all individuals who think that our modality might be superior or might be able to assist. And it is that important discussion clinicians need to have to establish what is really in the best interest of the patient. And I think Prem has given good results. Patrick has presented fantastic results. And we all sing really from the same hymn sheet that the most vital part of this kind of work is an experienced MDT.
So maybe I can address one of the questions that you could address one of the questions that's come up through the poll. Have you found a difference in the newer embolic agents in terms of an effects on the gamma knife?
No, to be honest, Prem, I don't think we can say that at this stage, because the numbers are small and you need to have a large group of patients to look at, statistical differences. And it's only that in the large group of AVM patients we looked at, that we are looking back at 1,400 patients. That's a large group. The difference was striking in a way, but the time has passed. These were the early embolizing agents, And I think the main issue from my point of view, or the thought process is either is it causing the radiation dose not to be delivered the way we think it is delivered due to the density of the obliterating agent. That's number one. The number two is, with Onyx, there is a question, is it actually leading to neovascularization? Is the body responding with building new abnormal vessels around this embolizing material? And those are questions I think it's too early to answer. There are some theories there, but I think in general, what I would prefer is treat first, embolize second. So say, for example, you have fast-flowing AVM, you want to think you can take the pressure off and reduce the rehemorrhage risk. What I would do normally, if you have that luxury of waiting and choice, irradiate the lesion first and then do the embolization to take the steam out of it. That would be my preferred way, but it takes a very well-functioning apparatus to facilitate that. Now, there's another question here. What determines the time period between stages of treatments? Just very quick at the end before Mary puts on some MDT forms as well. What I think the most important bit is that you stage in a timely fashion so that the gaps are not too big, because you want to have both parts or 2-3 parts of the AVM responding in a similar time frame. Otherwise, you get one part occluding much quicker, you change flow patterns, etc., and you might increase the risk of hemorrhage. So we usually stick to a timeline of 4 to 6 weeks between stages. But there are differences, as Patrick mentioned. Thank you very much for your interest. And, Mary and the team in Queen Square are very happy to answer questions or receive referrals. And there are forms for the MDT referral to take this forward. So please do be in touch. And thank you very much for listening in. And all the very best. Thank you.